Every year I have patients come into my medical office with newly diagnosed prostate cancer, and they ask me, what would you do? And very often I just have to sort of shrug my shoulders and say, I'm not exactly sure. And the reason is that this is a very difficult, complicated, and controversial field. Fortunately, we have here today Dr. Herb Lepor, who is a world's expert in prostate cancer. He is the head of urology at NYU Langone Medical Center and a colleague. Thank you very much for coming, Herb.
John, thank you for having me.
And in full disclosure, I am also at NYU Langone Medical Center, a newly minted member of the faculty.
And we're very proud of that.
And so I want to say we've worked together on patients. Talk to me about why this is such a difficult decision for patients.
So let's look at the spectrum of the disease. The youngest patient I've diagnosed is 37. Just last week I saw somebody 85. I have some men where the biopsy shows such a tiny cancer, and I don't even know if it's significant. On the other hand, there's men who will have such advanced disease, I don't know if I can help them. Others come in and say, cure me. My father died a miserable death. I'll deal whatever with I have to in order to be cured. Others will say, if I'm going to lose my continence or erections, forget it. I'd rather die 10, 20 years. So that's the spectrum of the disease, and it isn't a one-size-fits-all.
And to put this in perspective, almost 16% of American men are diagnosed with prostate cancer in their lifetime, but only 3% of American men die from prostate cancer. So how do you figure out who to treat?
It's tough, right? And the problem is we really have to get better at determining the risk of that cancer. We're very limited when we take a biopsy needle and randomly sample the gland and expect to really understand the risk. And that's the future challenge that we have in terms of risk assessment. We got to get better at screening, at detection, and then the answer to how to be treated is going to become much more apparent.
And just to give people an idea of how difficult the whole controversy is, there's a thing called a Gleason scale, right? Which is when you do a biopsy of the prostate and it comes back with cancer, it's a scale from what to what?
It's a scale from 2 to 10.
10 is the worst.
10 is the worst.
2 is the least.
2 is the least.
What about a Gleason 6? That's where the controversy is.
That's huge controversy, and we're even debating today whether that pattern that we see under the microscope is really a cancer. And what's a cancer? Something that spreads and is lethal. And it's really unclear if Gleason 6, the most diagnosed tumor, is that truly lethal.
Right, and so that brings us right to the middle of this controversy. I'm going to have a fake patient who comes in to see you, and I've got a Gleason 6. So I'm one of these people who may have a little cancer. Maybe it's cancer, maybe it's not cancer. We're using old-fashioned techniques, light microscopy. You're looking under the microscope, and maybe there should be something new where you can look at the cells and figure out which ones of them are going to kill you and which aren't, using molecular genetics, new kinds of techniques. But we're stuck with what we have, and I'm coming in, I say, what should I do? What are the different options that you can offer me?
So one is active surveillance, which is we don't think you have a disease that's lethal, so we're going to follow you. We'll maybe do a biopsy in a year or two, we'll follow your PSA. And then on the other extreme, we can surgically remove the entire prostate or try to destroy it with radiation. And again, sometimes the potential risk of treatment may exceed the benefits. And what I believe is what we're going to see in prostate cancer as we get better at knowing the risk and precisely where that cancer is. And we have a preliminary series. We put a laser fiber into a abnormality in the MRI machine, and we destroy just that area of the malignant gland.
So this is like a targeted therapy where you go after, and of course we're right at the beginning of that.
I think as our imaging gets better, and as our molecular risk stratification, looking at the various genes, we're going to be able to determine where that cancer is, how aggressive it is, and we're going to have something in between nothing and everything, and I believe that is going to help us treat this disease more effectively.
And hopefully that'll happen soon, because I can tell you right now it's really confusing for my patients. Dr. Herb Lepor, thank you so much for joining us.
Thank you.